Hello, my name is Dr. Ukiri Richard. I'm giving you the podcast again on basic cardiology. The topic today is acute thorax pain. A 65-year-old patient was sent from his house doctor to your emergency room due to suspicion of acute coronary syndrome. This patient has been experiencing severe intermittent chest pain since 3 hours, and the pain radiates to the back. He hasn't had such pain in the past. He has been a non-hypertensive for some years now, but because he has no problem or he has not been having any symptoms, he has not been taking his medications. The house doctor wrote an ECG where ST segment depression were seen. On general examination, his general condition was reduced. There were no signs, cyanosis or edema. Blood pressure was normal, was 130 to 80 left and 100 to 70 right. The pulse rate was 55 per minute and respiratory rate was 12 per minute. There was no jugular venous congestion. On auscultation, one could auscultate a 4/6 systolic murmur and a 2/6 diastolic murmur over the aortic valve. Examination of the respiratory, abdomen, and urological system had normal findings. So my question now is, what are your differential diagnoses? What differential diagnosis are you thinking of? Answer. Differential diagnoses here are 1. Acute coronary syndrome, aortic dissection, could be pericarditis or reflux disease, could be pancreatitis or musculoskeletal syndrome. It could also be pleuritis or pulmonary embolism. So, what would be the first diagnostic step that you will take? Well, the first diagnostic step I would take is to write an ECG, a resting ECG, do laboratory analysis to exclude an acute coronary syndrome. Okay, you have done an ECG and you've seen that the patient has sinus rhythm with heart rate of 55 per minute. There were discrete, slight ST segment depression in V5 and V6, as well as light ST segment elevation in V1. Note that ECG findings in aortic dissection are not specific. In 1/3 of the patient, you can see ECG changes like those of left ventricular hypertrophy, but if the coronary arteries are involved by the dissection, you could also have ST segment elevation like that of myocardial infarction. While you are monitoring the patients, you saw that the blood pressure on the right side went down to 80/60 millimeters per mercury with a heart rate of 55 per minute. The patient was still in pain. The transthoracic echocardiography showed a dilated ascending aorta of 5 centimeters. The aortic valves were okay. What diagnosis do you have to immediately exclude, and what diagnostic measures will you take? Answer. An acute aortic insufficiency from an aortic dissection. The diagnostic tools are computer tomography of the thorax, transesophageal echocardiography, and magnetic resonance tomography. The decision of which diagnostic tool to use depends on how stable the patient is from circulatory state, the renal function, contrast medium allergy. It also depends on the sensitivity, specificity, and the availability of this method. For example, the transesophageal echocardiography, it can help you to assess the proximal ascending aorta. It can also tell about the aortic insufficiency and the morphology of the valves, but sensitivity is 80%, specificity 96%. In the transesophageal echocardiography, the sensitivity is very high, 89 to 99%. Specificity is 89%, and it's also very available in stable patients. In computer tomography, you can see the whole aorta up to the iliac vessels. You can know the exact localization and the extent of the vessels and the dissection where there is one. Sensitivity here is 83 to 94%, and specificity is 87 to 100%. For MROT, the sensitivity and specificity are higher than those of computer tomography. But the disadvantage here is that the preparation for the magnetic resonance aortography, it takes a longer time, and the method is not always available. Another test you could do here is the DSA, that is digital subtraction angiography. The advantage here is you will also get information about the perfusion of organs. Some people still prefer to do coronary angiography as a preoperative measure to know the coronary status of the patient. Well, there are different opinions about this. It depends on the operator. Thank you very much. Now, could you tell me the etiology of an acute aortic insufficiency? Answer: bacterial endocarditis, aortic dissection, and trauma. Good. Now, what are the risk factors for an aortic dissection, especially thoracic aortic dissection? 1. High pressure demand on the vascular wall, like in arterial hypertension, fake chromocytoma, drug addiction like cocaine, and deceleration like deceleration trauma. Other risk factor are changes in the media, intima media, which could be genetic, like in Marfan syndrome, Ehlers-Danlos syndrome, bicuspid aortic valve, Turner syndrome, and family thoracic aortic aneurysm. Other things that can cause changes in the media are vasculitis, like Takayasu large cell arteritis, Takayasu arteritis, and Batchet arteritis. Also, another risk factor is post-intervention, either surgical or intervention or catheter intervention of the aorta. So I have a computer tomography picture that I'm looking now, and in the picture you are seeing dissection of the aortic arc that goes down to the descending aorta. It actually begins from the aortic valve and spread up to the iliac vessels. The supra-aortic vessels are also affected, but the celiac trunk, the inferior and superior mesenteric artery, as well as both renal arteries, were not affected. My question now is, what are the classifications you know for our aortic dissection, and what consequences do they have? Answer: I know the Stanford classification. In type A dissection, which is more common, the dissection starts from the ascending aorta and goes down through the aortic arc up to the iliac vessel. In type B dissection, the dissection is restricted to the descending aorta. That is from the aortic valve up to the aortic arc up to the descending aorta. Sometimes you have it starting from the level of the subclavian sinistra and may extend up to the iliac vessel. Here, the aortic ascendance and the aortic arc are not affected. The type A dissection requires immediate operation. It's an immediate operation indication. But for type B, you can handle it conservatively with bed rest and blood pressure control. So how do you see the prognosis of an aortic dissection patient? For stand 4 type A, the dissection, the prognosis is very bad. If you handle this patient conservatively, the survival rate is 2% after 2 months. But for type B dissection, lethality when you handle these patients conservatively is very low. It's even lower than when you handle them in surgical way. Stent implantation in acute aortic dissection is presently undergoing study. Just to inform you that this patient was taken to the cardiac surgical department for operative care. But for this presentation, very fast operation is necessary because the mortality rate is very high. Because the mortality rate in early phases, especially it's like 1 to 2% per hour. Just